Assalamualaikum, my name is Nur Fazila binti Ahmad Zaini and today I want to present about evident children with cerebral palsy. Firstly, for the introduction, the purpose of this study is to address to the first cause learning outcome which are described the principle of human development, the concept of motor control and motor learning, and international classification of functioning, disability and health, which is ICF in pediatric rehabilitation. What is motor learning? According to Montero 2013, motor learning is the capacity of the individual to perform a motor skill, inducing a relatively permanent improvement in performance as a result of practice or experience. Other defined as permanent of neuromotor changes that lead to the ability to perform motor skills. As we know that practice is the process of attempting to perform a task in order to develop a skill. What is cerebral palsy? Cerebral palsy is a complex neurological disorder which characterized by congenital motor disability and is associated with cognition disorder such as learning difficulties, perception disorder such as sensory abnormalities, and lastly, behavior disorders such as hyperactive and anxious. The study objective for these two articles, Buitrago et al. 2019, is to validate the effectiveness of 60-session physical therapy program to improve the participant and fulfillment of the therapeutic objective on 8-year-old boy with dyskinetic cerebral palsy for motor learning to walk using a social assistive robot. While study by Schnecker 2018 is to improve the bimanual skill of the child while minimizing the increase of therapy-related parental stress. And now, I will make a comparison between these two articles, which for the article 1 is by using social assistive robot, while for the article 2 is using home-based bimanual training. As for the study design, article 1 is a single case study, and as we know that this article used robotic intervention on a child with cerebral palsy. This study design will provide feasible alternative to large group studies such as randomized control trial, and it used to focus on only one particular unit. While for the article 2 is a protocol study that describes two protocols of home-based bimanual training consists of principle of implicit and explicit motor learning. This study is replicable and inform the scientific community about what studies being done and also to improve coordination of research efforts. Next, for the study setting, article 1 is at the gymnasium or rehab center. As we know that the therapist done the therapy or intervention and stay with the children. Compared to article 2, where the intervention occur at parents' home and the parents no need to travel to the exercise center and the intervention can be embedded to daily routine. This is because parents can do the activities with their children anytime at home. Next, we proceed to the participant recruitment, where for the article 1, the inclusion criteria was an 8-year-old boy with dyskinetic cerebral palsy and had level 3 of gross motor function classification system, had level 3 of manual ability classification system, and level 3 communication function classification system, including no health complication. Compared to the article 2, where it involved the children with unilateral spastic cerebral palsy that age from 2 to 7 years old, level 1 to 3 manual abilities classification system, and had level 1 to 3 gross motor function classification system. For the comparison of participant recruitment is, article 1 only focus on one subject, and it is good to test the effect of intervention using repeated measurement. However, the study should take more subjects to enhance the generalizability of the result, compared to the article 2, where the study had explored in more subjects, and it will provide more precise on effect estimation, and this study will produce better generalizability of the result. Generalizability is where the result of the study are useful for broader group of people, such as we can see that in the Article 2, it takes children from 2 to 7 years old, while Article 1 only involve one children that age 8 years old. For the procedure of Article 1, the use of now robot 50x cm tall with 4.5 kg of weight. It used goal-directed therapy to achieve the task. It has 16 sessions of physical therapy for 2 sessions per week for 45 minutes each session. First session was conventional therapy and the second session was motor learning to walk by humanoid robot as assistant. Next, procedure for Article 2 consists of preparation-based and home-based training. For the preparation-based, it has introductory meeting with remedial educationally for 60 minutes with parents, and then 60-minute meeting with therapists at the rehab center, and then design for individualized program and home visit. While for the home-based training is where the parents do the training at home with their cerebral palsy children. It consists of 3.5 hours per week, about 30 minutes per day and 12 weeks in total. Then, video recording, registration, telecoaching and home visit by the coaching team. Based on the procedure of the Article 1, the therapist who is more experienced conduct the training, where the therapist direct contact the children at the rehab center. Therapist and the humanoid robot give support, feedback and attention to the children. Next, is more consistent of motivation by using humanoid robot, where the robot cannot get tired or exhausted during the training. According to Lab et al. 2016, robotic will increase efficiency to the therapy by consistent training for extended period of time. When we compare to the Article 2 where it involves parents to train their child, parents and therapy should evaluate the children together so it will define the need of the children. This can give the opportunity for the parents to learn more about their children. Intervention. However, the therapist only educate the parents through the phone. It might not enough because family and children easily to lose motivation, lack of supervised and harmful training may occur. In addition, children with cerebral palsy not willing to follow the instruction. It might cause trouble for their parents during the intervention. Next, we proceed to the variable of these two articles. The independent variable for Article 1 is humanoid robot, while independent variable for Article 2 is home-based by manual training. As for the dependent variable, Article 1 is the number of steps of cerebral palsy children without falling, while Article 2 is children by manual skill performance while minimizing the increase of therapy-related parental stress. Now, back to the comparison between the variables. For the Article 1, this article not minimizing parental stress, where the parents are not involved in training their children. Parents only send the child to the rehab center. According to Ribeiro et al. 2014, parental stress will affect care practice and cause the mother to more neglectful and violent that can worsen the behavioral action of their children. Compared to the Article 2, this article includes outcome of children while minimizing parental stress. By participating in rehabilitation of the children, parents were more adept in taking care and increase the confidence, including reducing parental stress, because the parents had learned to taking care and do intervention to their children at home. Next, for the outcome measure, Article 1 use goal attainment scaling to evaluate the result or outcome of an intervention based on individualized goal. According to the evidence, inter-rater reliability by children's therapists was 0.82, while inter-rater reliability by independent raters was 0.64. While Article 2 had two outcome measures which are Canadian Occupational Performance Measure and Goal Attainment Scaling. Canadian Occupational Performance Measure is used to assess perceived occupational performance in self-care, productivity and leisure, and it has internal consistency of Krombacher Alpha performance 0.73 and satisfaction 0.83. So, when compared, in Article 1, therapists that not participate in the training will evaluate their children by using this outcome measure. This method can give good result and reduce the bias in interpreting the children after the intervention. While in Article 2, where the parent share the video recording to their coaching team once a week, parents and coaching team will evaluate the children's performance. This method may result in bias where the parent itself will rank their children's performance. Now we are at the result. As for the result of Article 1, the children show increased number of steps continuously in goal attainment scaling in session 5, 11 and 16. While for the Article 2, where the children will learn new skill in home-based training within their natural environments, and parents also will be more involved in their children intervention. As for the comparison of the results between these two articles, for Article 1, the result of this article was tabulated in detail according to goal attainment scaling scale. The results show that the children was improved based on 3 sessions. Writing result section was important for the reader to understand clearly about the study, and it will make easier for the reader to understand the intervention. While for the Article 2, no data about the result on each session. The data was general rather than specific improvement or benefit of implicit and explicit principle of motor learning. Now, we are at study limitation. For the Article 1, if the children take rest, result will be biased because after rest, it will improve the children's stability and control to continue the training. Next, it is not clear whether the result was due to assistance from humanoid robot or due to therapeutic process that had been carried out before this study. Limitation can be seen when it only involves an individual. It will cause lack of generality of the result and effect obtained. Other limitation is this study only suitable to create hypotheses for future research. Lastly, new definition of objective was made, but the task or the environment was not changed or modified. While for the Article 2, study limitation is bias in outcome assessment. Based on evidence, bias led to false conclusion and potential of misleading. Next, evaluation by focus group that can cause researcher bias in conducting the protocol study. Focus group include the parents and other physicians or experienced remedial educationalists to design the study protocol. Next, parents know the intervention that going to conduct. Published protocol could give participants the chance to prepare for the training, and it will affect the outcome. Other than that, the researcher not located near of the study setting. This where the researcher are not supervised directly during the occurring of the intervention at home. Lastly, parents do the rehabilitation at home. Based on the evidence, unprofessional therapists may give adverse effect during the therapeutic rehabilitation. In conclusion, what study that I prefer the most? I chose Article 1. This is because the humanoid robot are more interesting for the children, where the humanoid robotic might be regarded as their friends, because the robot was tall about 58 cm like a child. Next, the humanoid robot will draw the attention from the children with cerebral palsy. Then, the humanoid robot has two-way communication, where the robot can talk and give feedback to interact with the child. Lastly, it can produce repeated and controlled movement. This is because robot not tired of repetition. Robot can perform repeated tasks. Alright, that's all from me. The end.